Hi, this is Darwin Labarth. I'd like to talk with you today about the concept of cardiovascular health, where it came from, where it's leading, and in particular, the research questions that have arisen as we begin to learn more about this concept and the phenomenon of cardiovascular health. A key point in this development was a publication by Lloyd Jones and others based on data from the Framingham Heart Study. It concerns the cumulative incidence of major cardiovascular events among people aged 50 at the baseline for this analysis, until their death or occurrence of a major cardiovascular events. They may have reached as late as age 95. What do we see when we look at this figure? I think the first thing most would see is the curves on the top, related to having two or more major risk factors within this study population. 69% of men, 50% of women experienced major cardiovascular events over this follow-up period. But if we look at those with optimal risk factors, what we find is a much reduced rate, 5% for men, 8% for women. The virtual disappearance of major cardiovascular events beyond age 50 in those at optimal level of risk. What's the explanation? Holmes would have said to Watson, "My dear Watson, it's elementary. Absent the cause, its effects cannot occur. Absence of the cause, with optimal risk factors, the cardiovascular events cannot occur." This observation didn't originate with the Framingham study in 2006, but an earlier paper is very instructive from 1957, 50 years earlier, reporting on the coronary heart disease experience in the Framingham study in its earliest years. The authors wrote, "Consider first the bottom group, which includes the 11% of the men 45 to 62 who were characterized by low values in all three variables, that is blood pressure, Framingham relative weight, and cholesterol. The incident rate for this group was 10 per thousand, a rate even lower, they wrote, even lower than that observed among all women of the same age, of 29 per thousand. More recent observations than the Framingham 57 report was from 1999, Stamler and others, describing observations in long-term follow-up of the Chicago heart industry and Mr. Fit cohorts from the multiple risk factor intervention trial. The men screened and followed for their subsequent cardiovascular events and mortality. What did they observe? Based on these very large cohort studies, for individuals with favorable levels of cholesterol and blood pressure who do not smoke and do not have diabetes, MI, or ECG abnormalities, long-term mortality is much lower and longevity much greater. A substantial increase, they wrote, in the proportion of the population at lifetime low risk could contribute decisively to ending the CHD epidemic. Increasing the proportion of the population at lifetime low risk could contribute decisively to ending the CHD epidemic. At CDC, we took the opportunity to collaborate with Simon Capewell and others in Liverpool to apply their CHD impact model to data from the US, looking forward from 2000 to 2010. Our question was, what if the whole population achieved low risk? Several scenarios are represented here in showing the coronary heart disease deaths per year, beginning in 2000 and extending to 2010. If the observed rates in 2000 continued, the red bars would indicate the numbers of coronary deaths expected in 2010. If the 2000 rates were unchanged, the green bars show the scenario, and the blue if risk factor trends, which were increasing at the time, were to continue. Black if the Healthy People 2010 targets are reached, following the national blueprint for health for the country as a whole over the decade from 2000 to 2010. But what if the population reached low risk? Coronary heart disease deaths would virtually disappear. From the expected number of 388,000 deaths, only 16,000 would be observed, about 4% of expectation. What's happening? Absent the cause, its effects cannot occur. This idea, based on these and a number of other studies prior to 2010, led the American Heart Association to commission a study to determine what cardiovascular health might look like, translating the idea of low risk into the positive direction of cardiovascular health. And so this report defined and set national goals for the AHA for cardiovascular health promotion and disease reduction. This is for the American Heart Strategic Impact Goal through 2020 and beyond. How is cardiovascular health to be defined? It was defined in terms of metrics that could be measured in the national probability samples of the National Health and Nutrition Examination Surveys, or NHANES, biennial surveys that provide information on these particular measures. What are they? Simply put, smoking status, physical activity, a healthy diet score based on consumption of fruits and vegetables, fish, whole grains and fiber, sodium, and sugar-sweetened beverages. Healthy weight, represented as BMI, blood glucose, cholesterol, and blood pressure. The concept was, for the American Heart Association, as a strategic goal, that improvement might be attained in population cardiovascular health if movement could be achieved from poor to intermediate to ideal. But first, let's note that the metrics are stratified by age between adults, persons 20 years and older in the population, and children. A fine point is that children are defined by different age bands in these criteria because different age groups are represented in the data collected under the National Health and Nutrition Examination Survey. Not all variables are recorded at all ages. All are incorporated from ages 12 to 19, and we'll see more about data for this band by age in a moment. But the concept, once again, was that cardiovascular health might be improved from poor to intermediate, or from intermediate to ideal. If so, population cardiovascular health could be improved, and reduction in major cardiovascular events could be achieved. And this led then to expression of American Heart's 2020 impact goal by 2020 to improve the cardiovascular health of all Americans, that is all major groups by race, ethnicity, geography, and others, by 20%, while reducing deaths from cardiovascular disease and stroke by 20%. I want to make a couple of observations before continuing with implications of setting this goal and definition for cardiovascular health. First, that the outcomes when ideal cardiovascular health is defined and followed from a number of prospective studies. The sum of the parts is only part of the picture. Cardiovascular health predicts incident cancer, cognitive function, depression, quality of life, compression of morbidity or relative well-being during the last years of life, and Medicare charges, in our situation, a representation of healthcare expenditures at ages 65 years and beyond. Another important point is that every metric counts. That is, the 7 metrics, 4 ideal health behaviors, and 3 ideal health factors all contribute to the benefit of ideal cardiovascular health, in contrast to intermediate or poor levels. And so from the optimum rate, about 4% or 4 per 1,000 events in the ARIC study, we see the increase with each loss of cardiovascular health factors, blood pressure, glucose, cholesterol. We see increase with loss of healthy behaviors, diet, physical activity, tobacco, BMI. And we see the compound effect of these, about an 8 or 9 to 1 ratio of incidence of major cardiovascular events per 1,000 population over the period of follow-up. Every metric counts, and more than the sum of the parts is the consequence of ideal cardiovascular health over a period of follow-up. So what is the status of cardiovascular health in a population? Again, from the National Health and Nutrition Examination Surveys in the US, we see this picture for adults. Ideal in green, intermediate in yellow, poor in red, shows the distribution of each of these factors from current smoking on the left to fasting plasma glucose on the right. And what we see is that except for current smoking and fasting plasma glucose, fewer than half of the population are in ideal cardiovascular health by these metrics: body mass index, physical activity, total cholesterol, and blood pressure, not to mention the miserable appearance of virtually no ideal cardiovascular health in terms of the healthy diet score. Recall that the metrics are stratified by age, adults and children. So if this is the picture in adults, what do we see in children? What we see is a very much higher proportion of population in ideal cardiovascular health in terms of each of these metrics. Again, diet stands out as a dismal measure and similar in that respect to adults. But nearly all of the metrics are predominantly in the ideal category for children. In this particular analysis, those 12 to 19 years of age. Let's look again. Adults, children. What do we see? What we see is a marked decrease in the prevalence of ideal cardiovascular health in terms of most of the metrics over the interval between childhood and adulthood. I'd like to show another figure which is similar in content, but a change in format that you will already have seen in the 2 Virani reports, 2020 and 2021, in the statistical updates from the American Heart Association. We see the same kind of picture. Each of the metrics, in this case, ideal is blue, intermediate is red, poor is green. And what do we see when we compare the upper band, age 20 to 49, with the lower band, age 50 and over, separately for each of the factors? For smoking, the first of the metrics, very little change. For diet, halfway down, very little change. For every other metric, there is a decrease in prevalence of ideal metrics for physical activity, diet, body mass index, total cholesterol, blood pressure, and glucose. What we see is the potential to preserve ideal cardiovascular metrics at 50% or greater in the 20 to 49-year age group prior to the further decline at age 50 and after. Opportunity in the 20s, the 30s, the 40s, potentially to preserve the ideal metrics in most of these instances. What do the metrics look like in longitudinal follow-up? What we have seen is cross-sectional data by age, which give us a limited picture of the true trajectory of change over the life course. We have assembled data from 4 long-term cohort studies in which serial measures were recorded of several of the metrics, not all. That is, diet, physical activity, and smoking were not assessed to the same degree or in the same manner across the 4 studies, and data on these metrics could not be pooled for that reason. What we have instead is the clinical CVH metrics, that is BMI, blood pressure, cholesterol, and glucose. From ages 8 to 15, pooling data from the 4 cohorts. And what do we see? We see that at age 50, there is a significant difference in trajectories among 4 groups. For example, those who begin at high levels and stay high through most of the life course to age 50. In most contrast, those in the intermediate with rapid decline stratum, of whom about 10% were the population in this band. Those in the high stable category, nearly 20% of the population, the others in between. What we noted in this analysis is that there are also significant differences in these trajectories as early as age 8, as early as we were able to see from these data. Where did these differences come from? When did they originate? How early were these differences in life course trajectories of ideal cardiovascular health established? An important question. This led us at Northwestern in the Department of Preventive Medicine to respond to an opportunity for funding from the American Heart Association for studies of cardiovascular health in children, to suggest a number of questions we felt were high priorities that we could address. So we proposed a center, which we've called Early Life Origins of Cardiovascular Health, Healthier, Earlier, through a collaboration between our Department of Preventive Medicine in the medical school, the Institute of Developmental Science Research, and the Ann and Robert H. Lurie Children's Hospital of Chicago, which is the basis for our pediatric collaborations. We suggested the following questions in each of 3 projects required of the American Heart Association when we applied: population, clinical, and basic science. In population science, we asked, what is the status of cardiovascular health from birth to age 8? And how do we practically measure and monitor CVH in order to modify it in early life? In clinical science, we asked, can we intervene to preserve CVH in early life? And does maternal fetal environment matter? In basic science, we asked, what are the molecular mechanisms and signals of CVH loss or preservation in early life? And we could add in response to intervention, as studied in terms of epigenetics, DNA methylation chiefly. With our colleagues in developmental science, we also asked a cross-cutting question: how do early neurodevelopmental health and the child's social environment modify CVH trajectories? Progress has been made on addressing these questions. We are now at the end of the 4th year and have about 12 months in which to complete the analysis and reportings of findings. What we can say, among other things, on an interim basis regarding these 2 questions is, first, these are the trajectories we were able to define by use of electronic health records from a large multi-practice collaboration in the city of Chicago. More than 200,000 children with at least 3 occasions of assessment of the clinical factors. Note again, the clinical CVH trajectories over time. These records do not yet provide the information needed for diet, physical activity, or tobacco that would be necessary to incorporate the full CVH score that would rank each of the 7 metrics and add the scores for each. So what did we find extending our observations of the life course back from age 8 to age 2? Still, at age 2, significant differences in the trajectories. When did these differences arise? When did they begin? We continue to ask the question and are pursuing the question, what are the experiences in the first 2 years of life and in gestation, and even maternal health in preconception? Lots of questions remain, and work is being done on many of them. But important to recognize is what we know. And what do we know? What does the life course of ideal cardiovascular health look like based on the information we have already? If you were to fill in the graph, what would you see? We believe this is what you see. If we consider kids about age 10, adults about age 50, we see a sharp decline in ideal cardiovascular health prevalence from maybe 50% at age 10 to 10% at age 50. What's wrong with this picture? If our aim is to improve the cardiovascular health of the population, and we are watching it disappear through growth and development and aging, we must recognize the impact of this loss on the cardiovascular health problem we are attempting to resolve, going perhaps so far as Stamler and others suggested in 1999 as to end the CHD epidemic. These observations alone lead to a profound question, simple but profound. That is, what is the life course of cardiovascular health in multiple populations? We've observed a loss in the US data. Some confirmatory data have been reported. But how commonly does this pattern occur? This we don't yet know. We could pose a hypothesis that a marked decline in prevalence of ideal CVH with age, beginning in childhood, leaving open the question how early, is universal, occurring in all populations. If so, this would mobilize interest, investment, research, practice policy development in many populations beyond our own. The approach would be comparative population surveys that are standardized across multiple populations to discover variation in trajectories of ideal CVH with age and their main influential factors. Marked decline in prevalence of ideal CVH with age, beginning in childhood, is universal, occurring in all populations. Testable through comparative population surveys. Multinational collaborative research, such as we will be proposing for the seminar. Let's go back to the picture we see previously on the life course, and again ask the question, what's wrong with this picture? We're watching the decline in ideal cardiovascular health with age, when ideally we would see universal ideal cardiovascular health at birth and preserved through life. There's a wide gap. How could it be closed? In principle, by two simple steps, not easy. Step one, stop the decline. Step two, increase prevalence at birth to 100%. And having stopped the decline, observe a life course of ideal cardiovascular health from the beginning to the end. To think further about this, we can ask, how does this happen? What accounts for the loss of cardiovascular health that we've observed? The life course for many begins with ideal cardiovascular health, though as we observe, perhaps not for all. But for many or most, it declines from ideal to intermediate and from intermediate to poor cardiovascular health over the course of life. Why does this happen? Unfavorable change in the metrics, both the behaviors and the factors over this period. What have we already learned we can do to change this picture, to alter this course? We can improve from poor cardiovascular health to intermediate and from intermediate to ideal through interventions that are very familiar to us. Interventions that bring about favorable change in cardiovascular health metrics, the behaviors, and the factors. What is this approach? It's primary prevention, described and perhaps best articulated by Jeffrey Rose in 1981. Jeffrey Rose, professor of epidemiology and public health at the London School of Hygiene, was a founding director and for many years a co-director of this seminar, beginning in 1968. In 91, he wrote, in the high-risk preventive strategy, we go out and identify those at the top end of the distribution and give them some preventive care. But, he noted, this strategy offers only a limited answer to the community problem of heart disease. Why? Because those at the top end of the distribution do not account for the majority of cardiovascular events that occur population-wide. They occur in the much larger middle distribution of the population, in which a lesser extreme of risk affects very much larger numbers of people. We're therefore driven to consider mass approaches, he said, of which the simplest is to endeavor to lower the whole distribution of the risk variable by some measure in which all participate. And he went on to say that, potentially more effective, and ultimately the only acceptable answer is the mass strategy. This is preventive, primary prevention. So going back to our picture, what does this look like graphically? And I'd suggest it looks something like this. Some of you will recall the story of Sisyphus from Greek mythology. A god who misbehaved was sent to Hades and condemned to push a large boulder up a mountain forever, being unable to reach the top and push it over the other side. Primary prevention is, in important respects, a Sisyphean task. We cannot get all the way to the top. If we relax a moment, prevalence of risk factors increases, and worst of all, other generations follow, unaffected by the efforts we make today. This leads us to another question. Is there more to the picture than primary prevention? An important answer is primordial prevention, as described by Strasser in '78. Strasser was a professor of medicine in Budapest, then on assignment at the WHO Cardiovascular Disease Unit in Geneva. He wrote, "Real grassroots prevention should start by preserving entire risk factor-free societies from the penetration of risk factor epidemics. Here lies the possibility of averting one of tomorrow's world health problems," he wrote in '78. With the understanding that in much of the world, there was little or no evidence of the risk factor epidemics up to this time. Therefore, if societies could be protected from their development in the first place, this would avert a potential world health problem. I wish to propose the term protoprophylaxis or primordial prevention, he said. To my knowledge, protoprophylaxis has never really caught on. Primordial prevention was slow to catch on in some quarters, but has become much more widely recognized today than before. So in our picture of the relation between cardiovascular health promotion and cardiovascular risk reduction, we see these important contrasts between primordial and primary prevention. Their objectives are different. For cardiovascular health promotion, it is primordial prevention. For cardiovascular disease risk reduction, remedial intervention. Emphasis, health assets versus health liabilities. Definition based on multiple health factors and behaviors versus single factors, one at a time, hypertension, high cholesterol, diabetes, obesity. Approach, integrated across these multiple metrics or isolated one at a time. The frames of reference are different, a public health and population reference for cardiovascular health promotion versus a clinical frame of reference for much of cardiovascular disease risk reduction. Evaluation in cardiovascular health through universal periodic assessment, we propose, versus selective and ad hoc screening in risk factor detection and treatment. The time course for cardiovascular health is the life course continuity. For risk reduction, episodic observation. The modes of intervention are different. Support of favorable metrics in the case of cardiovascular health promotion versus improvement of adverse factors in risk reduction. Social, environmental, behavioral, psychological interventions for cardiovascular health promotion, chiefly pharmacological intervention for cardiovascular disease risk reduction. So we see important distinctions between primordial and primary prevention. We have seen primary prevention in relation to the life course of changing, declining cardiovascular health. Where does health promotion, primordial prevention, fit in this picture? Well, we need to move over with primary prevention and provide room for healthy gestation, development, and aging, which have the potential to increase ideal cardiovascular health from the beginning and to preserve it throughout the life course. So what we see is a picture of the life course and the opportunities to influence it through collaboration between primary prevention and primordial prevention. And this leads to the second major question, part of which we have been addressing in our center in a preliminary way. Here's the question about cardiovascular health promotion and CVD risk reduction. Can cardiovascular health promotion be implemented effectively together with primary prevention to improve cardiovascular health, population, CVH? A requirement to do this work and to measure its impact is to have continuous monitoring of the metrics of cardiovascular health in practice in order to know whether intervention is needed or being effective. And so a hypothesis could be posed as a preliminary step toward addressing this larger question. A hypothesis that the prevalence of ideal CVH will be increased by widespread adoption of a tool to monitor CVH in primary care. What might that look like? How would this question be studied? Through implementation research in diverse communities and practice settings to evaluate use of a comprehensive CVH growth chart, analogous to the familiar pediatric growth chart for height, weight, and BMI, now expanded to include each of the 7 metrics for cardiovascular health. And what is the impact of having that information, knowing the current trajectory of the course of cardiovascular health, child by child, youth by youth, young adult by young adult, and the possibility of favorably modifying those trajectories, promoting what's working, and reversing, when possible, the adverse effects that occur. Let's come back to question 1. We've observed a pattern of CVH loss throughout the life course and ask how commonly it occurs. We propose a hypothesis that marked decline in prevalence of ideal CVH with age, beginning in childhood, is universal, occurring in all populations. And we propose to test this hypothesis through comparative population surveys, well standardized across multiple populations, to discover variation in the trajectories of ideal CVH with age and their main influential factors. What we've seen in work to date is ability to stratify the population in statistically distinct trajectories from as early as 2 years of age throughout the life course. We've observed continuing decline between the 20 to 49 year age band and those 50 years of age and older. We've observed the effect of the absence of cardiovascular risk on the occurrence or non-occurrence of subsequent major cardiovascular events. This question is a precursor to questions about intervention. This is question 1, and it will be the focus of our continuing work in the seminar to develop 1 or more proposals for comparative population surveys across multiple populations. In the next segment, we'll talk about moving from the question to the proposal. For now, you've been patient. We look forward to the next opportunity to talk together. Thank you very much.